Welcome to the North Carolina College of Resuscitation. I'm Jamie Jollis. I'm a cardiologist at Duke University. Along with thousands of colleagues in North Carolina, we're all working to improve emergency cardiac care.
I'm Chris Granger. I'm a cardiologist at Duke University, and I'd like to welcome you to this series of presentations on a very important project for the state of North Carolina. That is the Heart Rescue Project, or RACE CARS. And this is the project to improve survival for patients with cardiac arrest by 50% over 5 years in the state of North Carolina. And it has a series of proven interventions that we need your help with, that include interventions in the community to increase rates of bystander CPR and to educate the public to activate the EMS system when a cardiac arrest is identified. It involves the best practices by emergency medical services, including rapid application of defibrillation and best care in transportation and destination to the best centers able to care for patients with cardiac arrest, and then hospital measures that include primary PCI when that's indicated, therapeutic hypothermia, and best care for patients with cardiac arrest during their hospital phase, including consideration for implantable defibrillators. And by doing all of these things, we believe that we can be very successful in improving survival for patients with cardiac arrest.
Hello, I'm Dave Pearson, and this is exciting for me to talk to you about the hospital response for cardiac arrest resuscitation. This is obviously a very extreme endpoint of cardiovascular collapse, and a great, over the years we've been doing a wonderful job of excelling with resuscitation and getting incredibly great outcomes. So this is wonderful to talk to you about. No disclosures. I unfortunately don't make any money off any of the cooling devices that I'll be discussing today. Today, though, I do want to talk to you about post-cardiac arrest syndrome. Specifically, one major component of that is the resuscitation of the brain, and one cornerstone of therapy for that is therapeutic hypothermia, specifically in the hospital setting. So I'll certainly focus on some of that, as well as this whole concept of regionalization, where a resuscitation is taken directly to a cardiac arrest center or a resuscitation-capable hospital, and then ultimately transferred to a cardiac arrest center. And additionally, we'll talk about how some of this terminology and implementation is done via the RACE CARS recommendations. Obviously, we have huge discrepancies, as illustrated here, with cardiac arrest survival. Hopefully, with endeavors such as the RACE CARS initiative, we'll be able to narrow these gaps and eliminate some of these huge variations. So let's start by talking about the post-cardiac arrest syndrome. This is a very unique syndrome. We'll hear it relate to similar resuscitative endpoints as sepsis. However, post-cardiac arrest syndrome is definitely unique. You can see outlined the components of it. You have the brain component, the heart component, the systemic ischemia reperfusion injury, and obviously some precipitating cause. Now, the brain injury, the challenge with cardiac arrest is we get a fair number of patients back, but they ultimately succumb to a neurologic death, and more than 65% of the patients ultimately suffer from brain death. And so we need to resuscitate the brain uniquely in this post-cardiac arrest syndrome. In 2002, two landmark studies came out, one out of Australia and one out of Europe. These were randomized trials looking at therapeutic hypothermia, and these are the landmark studies where all the International Liaison Committee on Resuscitation, as well as the American Heart Association recommendations come from on using therapeutic hypothermia in the shockable arrest rhythms, VTAC and VFib. So these studies are the ones that, for the most part, there's been a ton of additional series, but these are the studies that tell us that therapeutic hypothermia does indeed work. Interestingly, therapeutic hypothermia is nothing new. This is a slide from one of the fathers of CPR, Peter Safar, who recommended hypothermia back in the 1950s and early 60s as part of the original CPR guidelines. However, even with great data and evidence to support the use of therapeutic hypothermia, we still aren't implementing it as much as we should. Although this survey represents an old data set from 2005, I have numerous sources listed on this slide where in Britain, Canada, even in some of the places that are using even more than in the United States, we're still only achieving about 60% utilization of therapeutic hypothermia in the post-arrest state. So in 2010, here's the American Heart Association's recommendation. Certainly we should be cooling patients. The 2005 recommendations, that was a 2A recommendation. Now it's a 1B recommendation for the shockable rhythms, but we really should be considering this in all arrest rhythms, including the non-shockable rhythms. And you can see here that it's a 2B recommendation in the PEA asystolic arrests. So let's talk just simply about how do you execute therapeutic hypothermia. There's essentially 3 phases. The first one is the induction phase. There's 2 adjuncts to that. You can basically put on ice packs and cold saline, as well as initiating a cooling device. That cooling device here is illustrated is one where it's just a cooling pads. There's essentially many others that you can use, and I'll show you some additional examples. But ultimately, you want to get the patient, you want to start the induction as quickly as possible and cool the patient as quickly as possible for the most part. And then you want to maintain that cooling for 24 hours at 33 degrees Celsius. Anything lower than that, you can run into some dysrhythmias and some additional problems. And really, the ideal goal temperature is still a big unknown, but for the most part, the general agreement is 33 degrees Celsius for 24 hours, and then controlled rewarming over around a 6 to 8 hour period to prevent the complications of that. Now, what cooling techniques can you use? Really, there's 2 basic types. There's surface cooling and there's internal cooling. When it's all said and done, both work equally as well. There's advocates in both depending on what device rep you're talking to, but surface cooling can easily be implemented with ice packs. The challenge with that, though, is it doesn't maintain that temperature range that you want very well. So most of the time, you're either going to be using some automated feedback circuit cooling device, such as an Arctic Sun, which was illustrated on that previous slide. But there's many other devices out there. They all work pretty much the same and equally as well. If you opt for closer temperature regulation, you can use an endovascular cooling device, cooling catheter. When it's all said and done, again, the most important thing you can do is institute cooling. It doesn't matter what cooling device you end up choosing to use. Here's some cool questions, pun intended. So are cold fluids efficacious? We hear about intra-arrest cooling, and what is the data to support that? And is there any data to support what is the ideal time to goal temperature? So let's jump into those. So cold fluids are efficacious. It's been shown in animal studies as well as human pilot studies to be quite effective as an easy adjunct to induction of cooling. So you can get patients' temperature dropped by about 2 degrees Celsius over about a 30-minute period. And this has been used very much so in the pre-hospital setting. Pre-hospitally, you'll see also ice packs being used. But this is a very easy, effective way to induce patients both pre-hospital and in the emergency department. Now let's talk about intra-arrest cooling. There are some centers that are, specifically pre-hospital, that are actually not just starting the cold fluids after they get return of spontaneous circulation, but starting it during the actual arrest. The data here is not robust, but certainly in animal studies, intra-arrest cooling does make a big impact. In human studies, here's a study that was done via Medic in Mecklenburg County, where they basically showed by instituting intra-arrest fluids, they had a return of spontaneous circulation that was higher in those patients that received intra-arrest cooling. So there might be more benefits than just brain resuscitation, and there might be some benefits to the heart in terms of getting that return of spontaneous circulation. The next question is, how fast do we cool patients? According to the animal studies, the faster you get the patient cold, or the animal in this case, the faster you get the animal cold, the better they do. So very rapid cooling, less than 2 hours, was shown to be very effective in the neurologic outcomes of these animals. Here's a study that shows that intra-arrest cooling in 17 dogs. So what they did is they induced a cardiac arrest model, and then they did either early intra-arrest cooling or delayed intra-arrest cooling, and a difference of 10 minutes of when you induce that cooling made huge differences in neurologic outcome. And you can see just illustrated on this chart that the early hypothermia group had significantly better neurologic outcome in this dog model. Here's some additional models that just looked at ice packs or cold fluids with intra-arrest cooling that do show that it does help with successful return of spontaneous circulation as well as neurologic outcome. For the most part, human studies are somewhat lacking in this area with a robust study, but for the most part, it's safe and reasonable to do intra-arrest cooling, but the message is the earlier you start the cooling, the better the patient will do. Here is 2 studies where you'll see that how fast do we cool people, and does that have any benefit neurologically? Here's 2 studies that are mixed results. Both of them are retrospective studies. There are no prospective studies looking at it. One actually showed that patients did worse the faster you got them cold. We have to take that with a grain of salt, because there's a lot of theories in terms of what that actually means. Were those patients worse off? Did they take a bigger neurologic hit, and that's why their thermoregulatory system is out of whack? Because subsequent study by Mooney and others out of Minneapolis showed that there was no difference with the time to goal temperature. However, they noticed that the earlier you started the fluids, the better the patients did. Specifically, a 20% increase risk of death for each hour delay in initiation of cooling. So moving on, there's more to resuscitation of the brain than just cooling patients. Blood pressure has a big key role with resuscitating the brain, and hypotension is certainly bad, as illustrated in this study of post-cardiac arrest patients, but also hypertension might actually benefit cerebral blood flow. So that's one of the key end resuscitative goals that you want to achieve. Here's another study where it was a retrospective review involving 136 post-cardiac arrest patients. They basically maintained their pressure with epinephrine to maintain a mean arterial pressure greater than 70 per their protocol. And they noticed that if they were able to achieve this goal within 2 hours, those patients had a much improved neurologic outcome. This is an interesting transitional slide just to laugh a bit at how they used to practice intubation and ventilation in residents back in the 1950s and 60s. This is just a slide showing a bunch of surgery residents practicing ventilation on their peers. But the transition for this is that ventilator management does play a significant role in resuscitating the brain. You'll hear that certainly hyperventilation is definitely not good for the brain. That turns out to be absolutely true. Certainly hypoxia as well is bad for the brain, but even hyperoxia is bad for the brain. And so what one study showed that there was a odds ratio of 1.8 for increased mortality if you maintained an FiO2 greater than 300. So for the most part, it's recommended that you titrate down the FiO2 as quickly as possible and just maintain a normal oxygen saturation and not providing too much oxygen. And as well, just maintain a normal or a near normal PaCO2. So avoid hyperventilation. So we've talked about the post-cardiac arrest syndrome specifically and how to resuscitate the brain. So now let's move forward with the heart. Here's a great animal study that shows that you can expect hemodynamic collapse when you resuscitate after a shockable rhythm arrest. You can see here with the red line that this is a swine model where if the arrest was greater than 3 minutes, you could see that the hemodynamic collapse was much more profound than the blue line where it was less than 3 minutes. So for the most part, expect hemodynamic collapse, since most of the folks we see are going to certainly have shockable rhythm arrest with downtimes greater than 3 minutes. Here's a great study that says there's more to this puzzle than what you might think of just cardiogenic shock. That's the first thing you think of. The heart is stunned, and certainly this is seen in the post-cardiac arrest syndrome. This was a study looking at 165 patients with out-of-hospital cardiac arrest. They noticed that the time was 6.8 hours when they saw the most profound hemodynamic collapse and drop in blood pressure. Interestingly, at 24 hours, when this myocardial dysfunction, this heart stunning, seemed to resolve and the heart seemed to be having a normal ejection fraction, there was still this hemodynamic state where the patient was notably hypotensive. And they noticed that the superimposed vasodilation was a key component to this when they were doing measurements. So there is a multifactorial shock that occurs. It's partly due to cardiogenic shock, sometimes truly profound cardiogenic shock just from the heart being stunned from a transient ischemic episode. But there's also circulatory shock, there's distributive shock with third spacing vasodilation, and this does mimic a sepsis-like syndrome. Is this important? Well, certainly based on this study, even a single episode of hypotension leads to an increased mortality. Now, whether this is cause and effect or just useful for prognostication, the goal should still be the same, which is expect hemodynamic collapse, expect shock in these patients, and resuscitate to a mean arterial pressure minimum greater than 70 in these patients. So moving forward, we can talk about some of the additional elements of the post-cardiac arrest syndrome. We talk about early goal-directed hemodynamic optimization in septic patients, and this has been evaluated in the post-cardiac arrest patients as well. And the three goals are preload optimization, most commonly done through optimizing fluid resuscitation with CVP as your endpoint, perfusion pressure support resuscitation via catecholamines and trying to maintain a mean arterial pressure usually greater than 70 or 80, and then perfusion optimization with SVO2 being the endpoint there. Here's a study that was a feasibility study to see if this was achievable to hit these CVP, mean arterial pressure, and SVO2 endpoints within a 6-hour period of ED presentation in the post-cardiac arrest patients. And basically, they just looked at historical controls, and they looked at this protocol that was implemented in 20 patients, and they noticed a 28% absolute mortality reduction. So these endpoints are important. Again, for the most part, you're resuscitating just a total body ischemia that has a reperfusion injury similar to sepsis. So you're going to want to do aggressive fluid resuscitation and catecholamine support in your post-arrest patients. presume it's from cardiac, and they have very minimal exclusions. The obvious ones, which is DNR and active bleeding, or if they were comatose before arrest, alluding to another reason from a non-cardiac process. Now, what were the arrest characteristics? 82% were witnessed, and they had a large number that had bystander CPR, which is wonderful. 3/4 were shockable rhythms, and 1/4 was non-shockable rhythms. And if you look at the stemming proportion, was about half. 44% had shock. So again, remember, post-cardiac arrest shock is certainly seen in a lot of these patients. And their mean downtime was 22 minutes. 56% of patients survived, and 51% survived with a good neurologic outcome. Again, they noticed that a 20% increase in death for every hour delay in the initiation of cooling. So this would point to we're likely benefiting when we're doing pre-hospital cooling. They really didn't notice a survival benefit when you reach the goal temperature. In their study, it basically said that the earlier you get them started, the better with regards to cooling. And here's some fantastic outcomes for neurologic outcomes. They noticed that for the local patients, 42% had a good neurologic outcome. From the transferred patients, 54%. So this is a feasible regionalized process when you're doing just as well from the transfer patient as well as the local patients. Just some interesting statistics that I pulled out. Age doesn't necessarily, although it does portend a worse prognosis, you could still get excellent outcomes even if they are greater than 75 years old or if they have a non-shockable rhythm. And additionally, what about patients with downtimes greater than 30 minutes? Of the 45 patients that had that, 16 of them, or 36% of them, had a good neurologic outcome. At Carolinas Medical Center, we have this protocol called the Code Cool, which we started in 2007, just to serve as another example of a regionalized approach that could be implemented anywhere. 265 patients have been enrolled, and we receive about 41% of our patients from 24 outlying facilities. There is more to the protocol than just cooling. We do a goal-directed resuscitation with aggressive fluid resuscitation via cold IV fluids. We resuscitate to maintain a mean arterial pressure greater than 70. We obviously induce with therapeutic hypothermia, and we avoid hyperoxia and hyperventilation from the strategies we discussed previously. Now, for how we rolled this out, we initially started with shockable rhythms only. We now include all cardiac arrests. And in October 2008, we then started enrolling hospitals that were in the region. And we said, you know, do you want us to help you set up a hypothermia protocol, or would you rather transfer those patients to the main center? And pretty much unanimously, all those facilities said we'd rather just transfer those patients into Carolinas Medical Center. Here's an illustration of most of the patients we see are within a 50-mile radius. In that Minneapolis study, they had up to 150-mile radius, which they had a transfer network for. We sent out educational posters, this one specifically, just to remind outlying facilities of that we did exist, and that if they had a cardiac arrest patient, that these were some guidelines to help them, because some of the facilities just don't see a huge volume of post-cardiac arrest patients. Just for comparison to the other study, in 2011 we have 55 shockable patients, and we had 23 non-shockable patients. And you can see there some of our survival statistics. Just to shine some light on these statistics, our non-shockable patients, we basically ask the question on all our cardiac arrests: what was their baseline neurologic status? So that the goal is not to resuscitate someone that is just going to be resuscitated and just remain in a persistent vegetative state. Our goal was to resuscitate individuals who do have a good quality of life and will benefit from an aggressive resuscitation protocol. So with that said, you can see here that the red line are patients that had a good neurologic outcome, and the dark line is patients that survived. So those lines being close to each other shows that most people that do survive ultimately survive with a good neurologic outcome. And you can see the comparison for local to referred. This did not reach statistical significance, so we are achieving similar outcomes with this regionalized transfer model. So let's talk about how we can consider some of these models in the Heart Rescue and Race Cars initiative. The Race Cars initiative is aiming to improve survival by 50% over 5 years. Those are lofty goals, but unless you aim high, you'll never hit your target. And again, these are this is the goal that we need to really work hard to achieve, and we've made huge strides thus far, and we'll continue to work hard to achieve that goal. I'm talking specifically about the hospital response, but obviously it takes an entire community, it takes a pre-hospital system, it takes a huge hospital system and a network of hospitals to bring this puzzle together to successfully resuscitate folks from cardiac arrest. The AHA uses a little bit different terminology. In the Race Cars protocol, it's been designated to the terminology of resuscitation capable hospital and cardiac arrest center. So let's talk a little bit about those different hospitals. So a resuscitation capable hospital is one that typically is the initial hospital where the patient is brought to, that can resuscitate the patient to achieve return of spontaneous circulation, as well as resuscitate them in the immediate post-resuscitative phase to initiate therapeutic hypothermia, and then initiate a transfer protocol so that they can receive the critical care that they need. They can get the continued therapeutic hypothermia that they need, as well as the cardiac care that they need via PCI, as well as defibrillator placement and assessment for that. So the resuscitation capable hospital needs to have ACLS protocols. This is not certainly is not unique, and most hospitals have these things. And certainly obtaining a baseline neurologic exam is important, because many patients benefit from receiving paralytics to mitigate that shivering phase when they're getting induced with either ice packs or cold IV fluids. Placement of 2 large bore IVs and EKG to determine whether the STEMI pathway and cardiac cath lab should be immediately activated, and then having those treatment protocols in place. Now, those on the previous slide are pretty much uniform in most centers, but now with this being a resuscitative capable hospital, early notification of the receiving hospital, early activation of a transport plan, and obviously getting the medical records over there, that's going to be a new step in a hospital system that decides to go this route. If they decide to implement a comprehensive cardiac arrest, post-cardiac arrest plan, that's fine as well. Most centers, though, are opting to transfer these patients that have already existing resources where they can resuscitate these patients. Initial important endpoints, though, during this immediate post-resuscitative phase are optimizing the blood pressure, again, resuscitating that post-cardiac arrest syndrome, maintaining the brain perfusion, maintaining body perfusion to help ameliorate that post-resuscitative state and systemic ischemia reperfusion injury that results. And then obviously the ventilator management items that were discussed previously. I say here, consider CT imaging. Interestingly, a lot of patients that have a shockable rhythm don't necessarily need CT imaging. You probably need more CT imaging with the non-shockable rhythms, but it'll just be important to protocolize that to determine, do you need to keep the patient to get CT imaging at the resuscitation capable hospital or at the receiving hospital. And obviously induction of hypothermia is an important part of that, and whether that's through ice packs or cold IV fluids, both work exceedingly well, and you can actually use both of them as well. And then most of the time, shivering is a sedation deficiency, except in the induction phase, where paralytics really do seem to help get that patient colder quicker. Now, for the cardiac arrest center, pretty much all those previous things apply. If the patient from a pre-hospital standpoint ends up being brought directly to a cardiac arrest center, then obviously you'll resuscitate accordingly. If the patient is ultimately resuscitated from a resuscitation-capable hospital first and then transferred in, then it'll be important to provide all the additional resuscitative care that comprehensive cardiac arrest center can provide, specifically the ongoing neurologic assessments, the PCI, the continued therapeutic cooling, the ICD evaluation, and then probably one of the most important things is providing a good rehabilitation resource. So again, the hospital response, this kind of outlines the two hospital models, and so it'll be important to have this protocolized at your institution. So the take home, aggressively resuscitate patients regardless of age or downtime, because we really, we're not very good at prognosticating these patients, and we're getting better and better